Good evening, one and all. Thank you so much for coming in. Yet another program by Online Dentistry, Exam Alert, Prosthodontics. Give us a couple of minutes more. Let's enter more people. We will be starting immediately. Good evening. Give us a minute more. We'll start in 1 minute's time. More people entering in YouTube as well as Zoom. Please give us some more time. Okay, it's 33. Zoom is getting stable. YouTube too. So good evening once again to Online Dentistry platform and our Exam Alert program, preparing final year students for their exam. We started this a couple of months before. This is the second round going on all final year subjects as well as some third year subjects we have covered. This is the second round of that going on. Thank you all for being with us, for coming in on time and listening to all. There are many names who have been attending all the programs without a single miss. Welcome to Online Dentistry. Online Dentistry form started way back in 2008 with the motto, redefine dental education. That's exactly what we did. We redefined the way continuing dental education is done. You see our offline programs all over India. We did training for dentists in multiple fields of dentistry. Started way back in 2008. But with the name Online Dentistry, many people asked, like, we started last year during the pandemic. No, we started in 2008, at least 10 years before the pandemic. But we named it Online Dentistry right at that time because we had online course contents, assignments, and all that going on right from 2008 onwards. So we named it Online Dentistry. But we truly became online in 2020 March, when the national lockdown was declared. Presently, we have more than 20,000 followers on our platform. Our presence is there in all social media platforms, Facebook, Twitter, LinkedIn, you name it, it's there. Myself, Dr. Binu Abraham, orthodontist is practicing in Kochi, and my partner, Dr. Jobby Peter, Professor and Head, Department of Pediatric Dentistry, Annu Dental College, Kerala. We both started this firm way back in 2008. He was is my consultant pediatric dentist in my clinic. And that's how we started discussions, and that's how we started. We have 10 centers across India at this point of time. Any of these places, when more than 10-15 candidates get together, we go there and do this offline programs. I'm talking about offline. But all the offline courses are suspended at this point of time due to the pandemic. We are planning to start offline courses soon. We will be announcing that. Now, it's going to be a big announcement because it's like almost 1.5 years since we did an offline program. Let's hope and pray that we get over this pandemic at the earliest and start real offline trainings also. Presently, what we are doing is free 1-hour webinars and 3 to 7 hour paid webinars. There are many free 1-hour webinars coming up, all about local anesthesias coming up, orthopedic movements at a young age. All a dentist should know about orthognathic surgery coming up. There are many stuff coming up. And then exam alert is the wing we started for undergraduate students. The first time we ventured into undergraduate students and started off with final year subjects, part 1, part 2 preparatory classes. Visual treat, we call it. You read a textbook 2 hours, 3 hours, but you listen to see these stuff in 30 minutes to 1 hour, makes a huge difference in your exam. That was the policy behind it, so that you will remember something and you will recollect, at least in the Viva, you will remember these talks that has been taken. Next one coming up is day after tomorrow, periodontics again, second round again by Dr. Joby Peter. This Sunday, we have a 1 full day program on clear aligner. Huge success program conducted at least 5 or 6 times in the pandemic time period. Now this Sunday, once more, we are doing it due to heavy request. And due to the pandemic, we have cut down the rates so minimal that anybody can attend and start incorporating clear aligners into their practice. That is this Sunday, 1 full day on clear aligner. That registration is almost closing. I think tomorrow evening, same time, is the closing time of this program. Anybody listening to me practicing dentistry, it's not a bad idea to get an idea about clear aligners, because it's a non-aerosol generating procedure. All you have to do is take an impression and send it to the lab. So it's always good to know some basic diagnosis and how to select a case, how to deliver the tray. Everything will be covered hands-on. And happy to announce that a company has even agreed to come and do a live demo on a patient, intraoral scanning, so that without even an impression, how you can do clear aligners by emailing stuff to the lab. That's also going to be covered this Sunday. And the huge announcement is our tie-up with Lincoln University, Malaysia. Faculty of Dentistry, Lincoln University, Malaysia. The tie-up happened a couple of months before, but officially launched the first program coming up next Sunday, not this Sunday, the Sunday after that, July 18th. Program is interceptive and preventive orthodontics. It is a great program for all the practitioners to identify crowding, identify mouth breathing, and moreover, you're going to get an international certificate from Faculty of Dentistry, Lincoln University, Malaysia. I take this opportunity to thank the Dean of Lincoln University for trusting us and allowing for the collaboration, so that our candidates are going to get benefited by this. 1 full day program, but watch out the timings. This is Malaysian time given there. Indian time is a little early, but it is worth a program. Anybody listening to me still not member of online dentistry, please WhatsApp to one of these numbers, 9847032 or 9446321220. We'll add you into one of the WhatsApp groups of ours so that you get all the notifications of the coming year programs. So now it's time to introduce Dr. Eldokoshi sir. See, I don't want to waste a second round, so I don't want to read his complete CV. He has already proved that prosthodontics can be taught in a simpler way in his first round. So much of reviews we got about his class. We wanted to have a second round with him. So let me introduce one of the finest clinician, prosthodontist, implantologist, speaker, great orator, international speaker, Sir, Dr. Elder Koshi, sir, it's an honor to have you here. That was the second round for our students wing of online dentistry. I thank you from the bottom of my heart for accepting our invitation and coming in, sir. Thank you very much. Over to you, sir.
Thank you. Welcome all to the program. Let me share my screen. So we'll start our today's session with some cast RPD topics, two cast RPD topics. So the topic is rest and rest seats. I had covered 5 topics in the last session, so today I'll be covering the rest of the 5 topics. So I hope that you people would have seen a cast RPD. I had not seen a cast RPD during my UG time. So this is a cast RPD. Cast means this is got a metal frame. Usually this metal frame is casted in cobalt chromium, and also some labs, very sophisticated labs, they make this cast RPD in titanium also. The advantage of making this in titanium is it is half the weight of cobalt chromium and it is more harder than cobalt chromium. So these are the 2 materials that is generally used in making cast removable partial dentures. So we'll take the topic called rest and rest seats today. A rest seat is a prepared recess in a tooth or a restoration, which is developed to receive the rest. These rests may be occlusal, gingival, incisal, cingulum, or lingual rest. Okay, right. So what is a rest seat? You see on the tooth, you prepare a small kind of a cavity with certain measurements, which I'm going to tell. So you make different shapes in the tooth, and this shape is being prepared so that a rest will come and seat on this prepared rest seat. So these are the different type of recesses that you prepare on the tooth surface. So the classic definition of rest is a rigid extension of a removable partial denture that contacts the occlusal or incisal or cingulum region or the lingual surface of the tooth. It can be made on the tooth as such, or this rest can be prepared, this rest seats can be prepared on a restoration, on a crown maybe, and the surface of which is commonly prepared to receive it. So if you can see this is the rest. This is the rest. This is the rest. This is the rest. What are the functions of rest? The main function of a rest, this is the rest, is to transfer the forces. When you bite here, the forces get transmitted into the long axis of the tooth. So that is the primary function of a rest. Also, since the tooth has got periodontal ligament all around, when it is stressed, when biting forces come on the pontic region in here, what happens is the stress will get absorbed by the periodontal ligament. So that is another function of the rest. Since this rest has got an attachment, a guide plane, this rest will prevent food from being entrapped in between the next tooth and the rest seat. So that is another important advantage of having a rest. So this guide plane will prevent the entrapment of the food between the tooth and the rest seat. It also will act as a vertical stop. So whenever you bite on this, since it is supported on the prepared tooth surface, this will act as a vertical stop, preventing the settling of the denture on to the ridge surface. And also, since this clasps are rigidly attached or casted with the rest seat, this will maintain this clasp in its dedicated position. So these are the functions of the rest. Now there are different types of rest. So generally there are two different types of rest. One is called as a primary rest. So what is a primary rest? Any rest that is generally coming near an edentulous region. So this is an edentulous region. So a rest that comes near to an edentulous region, generally it's called as a primary rest because it's a part of the clasp assembly, which is the direct retainer. So primary rests come very near to the edentulous region. And secondary rests, also called as auxiliary rests, are additional rests that you give somewhere else other than the edentulous region. And this would probably will act as an indirect retainer. So if you look at this picture, this is the primary rest and this is an indirect rest. I'll show you one more picture. So this is an edentulous region. This is an edentulous region. So the arrow which is inside this red marking, this red block, this rest is a primary rest. Whereas this rest which is away from the edentulous region will be an auxiliary rest or a secondary rest. And there are different other rests, like when you prepare a rest seat for receiving a rest on an occlusal surface, it is called as an occlusal rest, usually given in molars and premolars. When it is prepared on canines, especially at the cingulum, it is called as a lingual rest. And those prepared on the mandibular canines and also on the mandibular incisors, they are called as incisal rest. So generally, these are the different type of rests. So we'll see the different forms of rest as we have described. So one is an occlusal rest. So this is an occlusal rest. You prepare a rest seat on the occlusal surface of the teeth. And this generally it's in triangular shape and it has got a rounded apex. It should not be very sharp because casting will be difficult in sharp regions and it can lead to improper casting. So it is at the tip, it will be generally a rounded shape. And it will be like a saucer, or you can call it as a spoon shape. If you look at the internal region, it will be a spoon shape. There will be no line angle. If there is a line angle, probably that can prevent the seating of the denture. And buccolingually, it will cover almost half the width of the buccolingual region of the tooth. And mesodistally, it will cover 1/3 or half of the mesodistal width of the tooth. You see the floor of the rest seat, it should be less than 90 degrees. We'll see why it is less than 90 degrees. So the angle between the rest seat and the proximal surface should be less than 90 degrees when you prepare the rest seat. Why should you do that? Because otherwise this region will act as an inclined plane. You see this floor of the rest seat is apical to the marginal bridge. So it is like this. It goes into the tooth like this, so that it will prevent the slippage of the denture. See, if you prepare a rest seat like this, a square-shaped rest seat, what will happen is it will lock the denture and it will not allow the horizontal movement of the denture when it is in function. So probably that can result in rocking of the tooth itself. So that is why you don't prepare it in a box shape. You prepare it like a spoon. So you make it the undersurface of the rest seat, it is more than 90 degrees, because this will not allow the slippage of the denture. Otherwise, it will act as an inclined plane, and this will result in slippage of the denture. Now, what should be the thickness of the rest seat that you're preparing? It should be 1 millimeter in thick minimum. So how do you check whether you have prepared 1 millimeter? What you do is, the easiest way is to put a periodontal probe into the into the cavity which you have prepared, or you can ask the patient to bite on a wax ring, and then you can measure the thickness of the wax ring at that rest prepared region with an Evanson's gauge. So what are the precautions when you prepare a rest seat? The functional cusp should never be reduced. That is the main thing that you should be noting in this. Second point, second type of rest is a cingulum rest. So where do you give a cingulum rest? What is the shape of the cingulum rest? Cingulum rests are prepared on the canines, that is on the maxillary canines. It is not prepared on the mandibular teeth. Why cingulum rest? Because the cingulum rest will be more closer to the center of rotation of the tooth. So all the forces that you direct will be concentrating into the center of the tooth. What is the shape of the cingulum rest? It is in an inverted V shape. And it should be less than 90 degrees. So this is an inverted V shape that you give. This is an inverted V shape for the cingulum rest that you give. Cingulum rest can be prepared on the natural tooth also, or it can be prepared on a restoration. You can give a crown in which you incorporate this shape. So that is the V shape that you give. One thing that you should be careful in this is that it should not be ejecting out away from the surface of the tooth. It should merge with the tooth. And when you load the tooth, it should not cause migration of the tooth to the buccal region. So that is why you should give a V shape. And it should be blending to the occlusal harmony of the tooth. So this is the dimensions that you should give. It is depth is 1 to 1.5 and the width is about 2.5 to 3 millimeter. So it should direct the forces of mastication parallelly into the long axis of the abutment tooth. That is what is most important. So here we have prepared a crown and then the cingulum rest is incorporated into the crown. Third is the incisal rest. This is not very advisable. It is given in mandibular canines and also in the distal incisal angles, and it is very visible also. So that is why it is not very much recommended. When there is no other means of supporting, that is when you will go for an incisal rest seat. So what you do is a V-shaped notch at the proximal surface angle of the teeth, and it is 1.5 to 2 millimeter. The deepest part of the preparation should be towards the center of the tooth, and the problem is it will extend facially, and so it might be anesthetic. So it is very rarely used. So that completes the rest. So to summarize the rest, there are different type of rests, and rests are seated on rest seats. So you prepare the rest seats on the cingulum or on the occlusal surface of the tooth, and it should be not locking the denture into the rest seats that you prepared. Next, we'll see the major connector. So my topic, what I've put is only maxillary major connector. Then I thought, for completion's sake, I'll take mandibular major connectors also. So we'll see the general characteristics of a major connector. The function of a major connector is to rigidly unite all the parts of the processes. I'll show you what a major connector is. So to unite one side to the other. So if you have seen a cast RPD, or if you have not seen a cast RPD, this is a cast RPD. So you see it has got edentulous region on both sides. So a major connector will unify both the sides of the edentulous region, or both the side of the processes. You connect it by means of a major connector. So this is a major connector that you give. Okay, so that your processes will be very rigid. It won't flex. Okay, so the major function is to rigidly unite one side to the other side, and also to rigidly unite all the parts of the processes. So that is your major function of the major connector. Also, cross arch stabilization means it will stabilize the denture on both sides, from both sides. So this is cross arch stabilization. The requirements are it should run parallel to the gingival margin. So you see this has to run parallel, this region has to run parallel to the gingival margin. So wherever it crosses the gingiva or it is near to the gingiva, it should run parallel to the gingiva. And any gingival crossing should be at right angle. So you see this, whenever it crosses the gingiva, it should be at 90 degrees to the major connector. So that is the main two requirements of a major connector. So we'll see the different types of major connector. You see this runs parallel to the gingival crevice. It runs parallel to the gingiva. So these are mandibular major connectors. The maxillary major connector, the border of all the major maxillary major connectors should be 6 millimeter from the gingival crevice. It should be 6 millimeter away. So that is one rule when you give a maxillary major connector. And whenever it crosses, it is near to the rugae. You see there are elevations for the rugae. They have got depressions, valleys of the rugae. So it should end in the valley of the rugae. And in mandibular major connectors, there should be at least 8 millimeter space required between the floor of the mouth and the gingival margins. This is for 5 millimeter for the bar and 3 millimeter space between the gingiva and the superior border of the bar, so that your gingiva gets stimulation with the tongue or when you brush, like that. So for mandibular major connectors, generally they say you require 8 millimeter of space from the floor of the mouth to the gingival crevice. Now we'll see the maxillary major connector. So those were the general qualities of a major connector, mandibular and maxillary. I've separated and told you that. Now we'll see the maxillary major connector, different types of that. One is a palatal strap. So this is a palatal strap design. This is a palatal strap design. It's a wide band of metal that crosses the palate. When do you call it as a strap? The width should be more than 8 millimeters. So when the maxillary major connector that crosses the gingival, that crosses the palate, it is more than 8 millimeter, you call it as a strap. It will give more palatal support because it is more than 8 millimeter wide. So it will take up the palate, it will make the palate take up more force when you chew. And it is indicated in unilateral distal extension cases. So that is the indication of a palatal strap. The problem is because it is very wide, this can cause papillary hyperplasia underneath the palatal strap. So this is a palatal strap. You see the width of the strap. It is, when it is 8 millimeter minimum, you call it as a palatal strap. So since it is causing papillary hyperplasia, probably you may think of decreasing the width of the posterior strap. So when it is less than 8 millimeter, you would call it as a bar. And if you cross section it, it will be a half oval shaped bar. And the indications are, it is limited to replacing 1 or 2 teeth bilaterally. It is generally not indicated anterior to the premolar, meaning it is indicated in the posterior region, and it is not given in class 1 and class 2 situations. The disadvantage of this is, since it is less than 8 millimeter in width, it gains less support from the palate. And it is, the disadvantage is it is less rigid because it is half oval in shape and also it is less wide. So it is less rigid. Next is a anterior-posterior palatal bar. You see there is a bar in the anterior region and also the posterior region. So just by looking at this, you will know that it has got 2 crossing over bars, which means that it will add to the rigidity of this restoration. So since it is two bars and connecting by two horizontal bars, it gives a circle effect, it is called as, meaning it will help in giving more rigidity. Otherwise, it is also called as an L-beam effect. When is it indicated? You see the maxillary palatal region is open. So it can be given in cases where the patient has got tori, and also when an anterior posterior abutments are widely separated. The contraindications are, it is not indicated in high walled cases. Another kind of maxillary major connector is a horseshoe. In horseshoe, you eliminate the posterior bar. So the advantage is it is U-shaped. Patient's tongue is more free than the anterior posterior palatal bar, and it is indicated in replacing anterior teeth. Generally, it is not indicated in class 1 situations. It also can be used in maxillary tori patients. The problem with this is that because it is not connected at the posterior region, it may flex during function. You can see that this may flex. You see, this is lesser in width, and when you leave the hand, it flexes. So that is one disadvantage of giving horseshoe. And fifth is when you give a strap in the anterior and the posterior region. Previously, we had seen a bar, but this is a strap. So what is a strap? When it is more than, when it is 8 millimeter wide, you call it as a strap. So this also gives a circle effect and also an L-beam effect. Another advantage is because it is more wide, it will give more palatal support. And it is indicated in class 1 and class 2 when the anterior teeth are to be replaced. So this is a circle beam or an L circle effect or an L beam effect. You see, this is in a circle shape, so it adds to the rigidity of the restoration. And see this, when especially the anterior region, it is in two planes. So that will add also to the L beam effect, also to the, meaning it will also help in adding to the rigidity of the restoration. And the sixth type of maxillary major connector is a complete palate. So you cover the whole palate. So since it is covering the whole palate, that means that it is very, very rigid. It is the most ultimate, it gives the most ultimate rigidity and support from the palate. And it can be kept 6 millimeter from the marginal gingiva. And if you take it over to the cingulum, then it should cover the cingulum of the anterior teeth. So it can be done in both ways like this. So if you make it in cobalt chromium, it will be a little bit more thicker. So it is advisable if you make it in titanium, since it is covering the whole palate, it will be of a lesser weight than the cobalt chromium, and it will also be more rigid than the cobalt chromium. And since if it is made in titanium, it will take only very lesser tongue space than cobalt chromium. So that is another advantage if you make it in titanium. So that's the complete palate. Complete palate can be used in replacing both bilateral posterior teeth and in class 2 and class 1, and also if you want to replace an anterior teeth in between. And I'm sorry about this, about the full, this is a mistake. So the tips when you replace using maxillary major connector, you can give a complete palate when the abutments are weak. So probably you can add more whenever you extract periodontally weak teeth, you can add to the complete palate restoration, complete palate major connector if you have given. And if the teeth has got good periodontal support, you can either go for anterior posterior bar or a strap. In class 1 and class 2, also you can give a complete palate. And class 1 and class 2 and also anterior teeth, if you want to replace it, a horseshoe or a complete palate can be given. If there is a tori, you can give an anterior posterior bar. and single palatal bar is generally rarely done. Now we'll quickly see the mandibular major connectors. It is half pear shaped to add to the rigidity. The types of mandibular major connectors are a lingual bar. So this is a lingual bar design, a single piece of bar going, and it goes underneath the tongue so it won't obscure the tongue space. And it's the most frequently used kind of mandibular major connector. And as I've said before, it's a half pear-shaped bar. As we had seen before, it should have at least 8 millimeter of space from the floor of the mouth to the gingival crevice to give a mandibular lingual bar. It is indicated in class 3 situations. The advantage is it gives minimal contact with the tooth. Disadvantage is because it's only just a single bar going, it is not very rigid. So you see, you extend it onto the cingulum, then you call it as a lingual plate. So there's a bar here, like a lingual bar, and then you extend the metal onto the cingulum of the tooth. So it will add to the, you can just, by looking at this, you will know that there is more metal, which means that it will add to the rigidity of the restoration, less flexing of this restoration. So it is a half pear-shaped bar with a metal plate extending onto the cingulum and also to the contact points. The top portion should be very thin and scalloped so that the tongue won't go and always scratch that region or find the margin. Another thing to be noted is it should always be supported on both the ends by the rest. Usually this is a rest seat prepared on the both sides of the first premolars, and it will contribute to the indirect retention. So you see that this is a half pear-shaped bar going, and then there is a metal piece that runs onto the cingulum. It should be supported on both sides by a rest on a prepared rest seat on the mesial fossa or the premolar. That is what we generally do. You can see that it has got a rest seat prepared. What are the indications of this? It is indicated for class 1 and class 2. And since there is a big metal plate coming there, it will help in indirect retention and insufficient space for lingual bar, then you can give a lingual plate. And when there is a mandibular tori there, then at the both sides, then you can give, you can extend this in the anterior region so that it will add to the rigidity of the restoration. And heavily resorbed posterior ridges, since it has got a bigger plate coming in the anterior region, it will give horizontal support and also lateral stability. What are the advantages? Since it has got a big plate coming onto the lingual surface of the tooth, it will add to the rigidity of the tooth, meaning when it can splint a periodontally weak anterior teeth. It will support the weak anterior teeth. It is the most rigid mandibular connector, and since it covers a lot of surface area, it will help in more support and stabilization. And because it is thinned towards the cingulum region, it can be acceptable by the tongue. The disadvantage is it will cover more of the tooth surface. So since it covers the more of tooth surface, what you can do is you can cut away a little bit from the in between this region. When you cut away the portion of metal in between the cingulum region and the lingual bar, you call it as a double lingual bar. You see two lingual bars are there, so you call it as a double lingual bar. Otherwise, it is also called as a Kennedy bar. So this is a Kennedy bar or a double lingual bar. Metal is removed from the superior margin of the lingual plate down to the half pear-shaped bar region. And there's a space between the superior half oval bar, that is the lingual bar, and the superior bar. And there is, like before, how we had seen in the lingual plate, there should be rest supporting it on both sides. Advantage is it also provides good indirect retention. Since we have cut the metal from in between, it will allow marginal gingival stimulation. Indication, it is indicated in class 1 and class 2. Also in anterior teeth, when there's a class 1, class 2 situation, with anterior teeth, which has got spaces in between, since in order to prevent the metal margin, metal being seen through, you cut away the metal from in between so that less metal is seen through the spacing of the anterior teeth. Disadvantage is that it has got 2 bars, it can interfere with the tongue. Next is a labial bar, which is not very generally favored by patients. It is called as a labial bar. This is given when you have lingually inclined anterior teeth and when you have a mandibular tori. Only a labial bar is given, and it is not generally very favored. It has got a clip here. You place it there, and then you lock this bar into this clip. So that is a labial bar. It is not generally very favored. So that completes the cast arpity section of today's lecture. Now we will see what is meant by a post and core. So this is generally asked as a short note. So post and core, I've put some clinical cases to show you. So we'll just see the definition first and then we'll go into the clinical aspects of that. So post core can also be asked as double core. So what is meant by a post? A post is that portion of the post core restoration that is fitted into the prepared root canal of the tooth. So this definition itself indicates that it's a dead tooth and you have done a root canal treatment onto the tooth. And then core is that portion of the post core that helps to retain a crown. So you have to learn this definition, and once I explain it, then you will be able to understand it more. Then I'll come back to the definition again. I would like to call this restoration as life of a tooth after the death of a tooth, or life after life of a tooth. See, this tooth is dead, and it is not just a root canal treated tooth, but this tooth is broken at the gingival level. Generally, just looking at it, it has no hope at all. You will feel like extracting this tooth off. But if you want, no implant is equal to a natural tooth. Natural tooth has got periodontal ligaments, so we should try to retain whatever natural tooth portion is remaining. If at all it is possible to retain that, we should always give it a try. So post and core is such kind of a restoration. We are trying to bring back a dead, a doomed tooth back into function and life. So what we do is we are going to do a root canal treatment. Now a root canal treatment is done, and I need to remove a little bit of the Gutta Percha from this. So it has been root canal treated. A GP is filled inside. So what we do is, with the use of a gauge grid burr, you start your entry into the axis, and then by means of piezo reamers, you should be well versed with piezo reamers. Generally, you've got six piezo reamers of different widths. So these are the piezo reamers. You can see the markings in this. Certain are 3. You can see 3 markings. Some are 2. There are 2 grooves in this. So like that, they will mark this piezo reamers. Piezo reamer 1, 2, 3, 4, 5, and 6, depending upon the width of the tip. So you insert this piezo reamer, and then you try to remove a portion of the GP. So this is how you remove the GP cone from the root canal treated tooth. So there are 2 ways of making a core and a post. So this is what is called as a burnout post. So you remove the GP point, and then you can make the impression of the canal by using what is called as a pattern dressing. So what you do is you lubricate the canal and then you insert this burnout post, and then you can build the crown portion of the tooth or the core portion of the tooth with general your self-care resin or a pattern resin after lubricating the canal surface, and then you make an impression. So you send that the shape of the core, this is the core, and the canal impression which you have made in the pattern resin. So you get it in acrylic resin, the whole post which goes into the root canal, and the core portion which you have made in pattern resin or your self-care resin is sent to the lab, and the lab will invest it and cast it, and you get a metal post. So this is called as a cast post, and then you insert the cast post into the root canal, and so this is a core portion that you have built up, and the post has gone into the root canal, and now you have cemented this. So this is a passive kind of post and core or a double core restoration. So this post should be quite long enough. So we'll see how much long it should be. Otherwise, this will result in fracture of the tooth if it's very short. Okay, and there should be quite an amount of root surface that is remaining, width of the root that is remaining when you prepare the post face. We'll see all that. And now you see the end of the metal that you see. From there, you can see about 2 to 3 millimeter of tooth surface. So this is what is called as a ferrule that you create. So ferrule is tooth surface that remains, or you prepare the prepared tooth surface that remains beyond the post margin is called as a ferrule. So you should also have a ferrule to support this post and core restoration. So you see this is from the lingual surface. So this is the core, and the function of the core is to support the crown that comes over it, and a ferrule, which means that the prepared tooth surface that is 1 to 2 millimeter, more than 2 millimeter, which is beyond the core margin, is called as the ferrule effect that you create. And you put a crown on the post and core that you've prepared. So this is one kind of restoration that you give. Another is a fiber post that you give. Same way, you create a post space for the post, and then a ready-made post like this, a fiber post you get, and then you prepare it. You place it into the root canal space that you have created, and then you can build it up with composite. So that is how we do it. So again, we'll see the definition. Post is that portion of the post-core restoration that goes into the prepared canal of a tooth, and core is that portion of the post-core that helps to retain the crown. So the length of the post in the root should be at least 2/3 the length of the root. So this is how it should be. It should extend at least 2/3 into the root surface, and at least 4 millimeter of GP minimum should be remaining there, and there should not be any space in between. So to get a good apical seal, at least 4 to 5 millimeter of apical GP should be retained there. So you use a gauge clearance to start with, or you can use piezo reamers as I've shown before to remove the sealer on the walls and also the GP point. You should conserve maximum radicular root surface. So this page, this figure 12.8 in Schillenberg will give you the amount of tooth structure that should remain there, and I would advocate you to draw this picture also. So the different type of post core that you give, the post systems, the classification is based on the mechanism of retention. When it's got threads in it, it is an active kind of post. So you thread the post into the root canal. It gives you more retention, but the problem is, since you are threading, you are producing stress into the root, and finally it can result in the long run, it can result in stress creation and root fracture. One which I've seen before, which I explained before, is a passive one. since you are making the impression of the root canal, or you get ready-made passive pose which doesn't have threads on it. Now we cement it into the root canal. So advantage is, since it is passive, it doesn't create stress into the root canal. Depending upon the design, you can classify it as smooth ones, serrated ones, and threaded ones. Also, depending upon the design, you can classify it as the parallel ones also, which you get it in same way, smooth, serrated, and threaded ones. Depending upon the availability, you can classify it as custom made and prefabricated. So this is custom made, which you have seen before, and this is the prefabricated ones that you get. And depending upon the material, you get it in metal. The disadvantage is it's very unaesthetic, but you also get it in ceramic. The problem is there are chances that it would break also. Depending upon the material, you can get it in fiber also, which is carbon fiber, which is black in color, but also you get it in white colored fiber post presently. Now, to complete post and core, if you have time, you should mention about Richmond crown. All these, the above mentioned, type of post, the core is separate from the crown, but in Richmond crown, the post and the core and the crown, all three are made in one single unit. So that is what a Richmond crown is. You may get a short note just by the name Richmond crown. So in such situation also, you should write about post, what is meant by a post, what is meant by a core and a crown. And in Richmond crown specifically, all these three are made in a single unit. This is a, generally what you do is, this is a post and a core, and it is made separately. But in Richmond crown, all these three comes in one single unit. You can also mention about Nayar post, which is, you take away GP points, little bit of GP point with a piezo reamer, and then you fill it with amalgam. And the core is also made in amalgam. So you can mention it as Nayar post is amalgam dowel core. So this is this would complete the post and core session. So I'll just read it again. A post and core crown is a type of dental restoration that is required where there is inadequate amount of tooth structure remaining to retain a conventional crown. The post can be cemented into a prepared root canal, which retains a core restoration and it retains the final crown. Function of the post is to retain a core and a crown, to redistribute the stress down onto the root and thereby reducing the risk of coronal fracture. The disadvantage is the post does not play any role in reinforcing or supporting the tooth. Posts make it more likely to fracture at the root. So the requirement of a post is you should get an adequate ferrule, which I have explained, a good amount of tooth structure beyond the post margin, and sufficient length of the canal to retain the post. We had explained that also. And you should know about the curvature and the overall anatomy of the root canal system. And there should be sufficient radicular dentin thickness for the post preparation. And the tooth should be restorable. So that completes post and core session. Two more topics to go. So next topic we'll cover is pre-prosthetic surgery. This is generally asked as an essay. So before you start your pre-prosthetic surgery, we should take the medical history of the patient, and there should not be any contraindication to the surgical procedures that we're going to do. We should take the dental history of the patient. There should not be, as I said, there should not be any surgical contraindication. And you should do a clinical examination of the patient, and also, if it is required, a radiographic examination of the patient. Why do you need to do a pre-prosthetic surgery? What you do is you should compare the patient's presenting condition with the ideal shape and form of an edentulous jaw or a ridge. So what is an ideal shape and form of an edentulous ridge? And you should see whether the patient has got this kind of a ideal ridge. So if the patient doesn't have an ideal ridge, then you should do a pre-prosthetic surgery. So the qualities of an ideal edentulous ridge is it should provide adequate bony support. It should have adequate buccal and lingual sulcus. There should not be any bony or soft tissue protuberances or undercuts on the ridge, no sharp ridges, and no peripheral scar or bands that would prevent the seating of a denture. And there should not be any soft tissue folds or depressions or hypertrophies on the ridge or on the sulci, and no neoplastic restorations. So 6 no's will define an ideal edentulous ridge. So what you do is you do a clinical examination of the hard tissues and the soft tissues. And when you classify pre-prosthetic surgical procedures, you can classify it as major and minor. And also you can classify it as those done on hard tissues and those done on soft tissues. So we'll see the minor pre-prosthetic surgical procedures first. One is the primary alveoloplasty that you do. So you all know what is meant by an alveoloplasty. It is done during your normal tooth extraction, or when you do a single unit extraction, or even a multiple tooth extraction. What you do is you can chip off the interdental bone or whatever is protruding. You can just chip it off with a raw edger. So that itself is a kind of alveoloplasty that you do. And then you compress the socket so that there is no protruding fractured bone pieces. And you can remove the interseptal bone, and when you compress, the ridge gets compressed. A secondary alveoloplasty can be, so that is the primary alveoloplasty that you do along with extraction. When the patient comes back after extraction, and you generally see that it is all ridge is all healed, but still there are certain elevations or sharp bone that can irritate the denture that comes over it, then you do a secondary alveoloplasty, that is after healing. So what you can do is a bony recontouring of all the alveolar ridges that you see. Then you need to put a flap again, and then you remove all those protuberances that you see here. Sometimes there will be maxillary exostoses. So you can also see a buccal exostosis. And these undercuts will make the denture insertion and removal very, very painful. So what you do is you will remove all this excess. Sometimes there could be palatal exostosis. It will narrow the palatal vault. When you do a surgery, you have to be very careful that you should not create a rupture of the palatal blood vessels, greater palatal blood vessels. I had personally undergone a rupture of a greater palatal blood vessel, and it was a terrible time that I had to stop the bleeding. So you should always be careful when you go near the molar region if there is a palatal exostosis and you want to remove it. Mylohyoid ridge reduction. If you make a denture at a mylohyoid ridge which is very prominent, it can result in ulceration of the lingual surface of the mandibular region. So what you do is it can, since it results in ulcers in the lingual flange, and also to improve the lingual flange extension. So when you have a prominent mylohyoid ridge, that will prevent the flange from being, inserted into the submandibular region. So what you do is you can trim away a little bit of the mylohyoid prominence. The problem with this is that you have to be very careful about the lingual nerve that comes on the lingual side. Genial tubercles, you see the very prominent genial tubercle. Generally, if you try to put your hand inside and feel for the genial tubercle, you won't be able to find the genial tubercle. But when there's a heavy resorption like this, then the genial tubercles become prominent. Sometimes it has become very prominent, and even it can come over the ridge. So there will be a thin mucosa that comes over it, and it can result in intolerable pain. So you remove the genial tubercle. Sometimes you will see tori both in maxilla and mandible. So it can result in danger adaptation and difficulty in speaking and eating. So you remove the tori. Mandibular tori is also a problem when you give a denture. So you can remove a mandibular tori with caution. Maxillary tuberosity, sometimes it will obscure the interdental space, interarch space. So you can remove it. And it will also, if it is present, it can result in denture displacement. So you would reduce the maxillary tuberosity to improve the interarch distance, and you can remove both maxillary tuberosities if it is very prominent, and sometimes you leave a little bit of prominence there, which will, if it is not very big. To come to soft tissue procedures, sometimes you see only soft tissue at the maxillary tuberosity. You can cut it off. So you'll remove an excess soft tissue at the maxillary tuberosity. Sometimes there will be soft tissue on the palatal aspect. So you remove the palatal excess with caution of the greater palatal artery that runs through here. Sometimes you'll see hypermobile tissues in the anterior region, especially when you have lower natural anterior teeth there, which is otherwise called as a combination syndrome. So sometimes also due to long-term wear of ill-fitting dentures, patient probably may not remove the denture at night. When you have natural anterior teeth, it could result in hypermobile tissues and resulting in poor denture supporting area, denture bearing area. So in such situations also, you try to remove those soft tissues. So you remove the excess soft tissues from there. And sometimes we'll see inflammatory fibrous hyperplasia, which has to be removed. If it is small, you can use an electrosurgery, or otherwise you have to do a normal surgery to remove it. Sometimes frenum, if it's very prominent, it might result in fracture of the denture, so frenectomy could be done. The examiners would expect these names, these terms. You give a diamond-like incision, and plasty is another kind of surgery that you give, or a V-Y-plasty. These three terms should be there while you remove a frenum, a frenectomy procedure. And major preprosthetic surgeries would be when there is a severe mandibular resorption. It could result in fracture of the mandible, so you can give a rib graft. So these procedures would generally be done under general anesthesia. Sometimes you take a rib and place it under the inferior border of the mandible, and sometimes you can keep a rib in between an interpositional space that is created in the mandible. And if it is a pedicule one, or otherwise called as a sandwich technique, that will maintain the blood supply of the graft from top portion and the portion below. And Weitzer osteotomy you can do when a bone is vertically mobilized and fixed vertically. You can do augmentation on maxilla also, which is otherwise called as a onlay grafting. Sometimes you can also do an interpositional grafting like how we did in the mandible. Here you generally take it from the iliac crest. When the ridge is very less, when you don't have enough attached gingiva to gain more denture bearing area, you can do a ridge extension procedure or a vestibuloplasty. Generally, you can do what is called as a lip switch procedure, otherwise called as a transpositional vestibuloplasty, wherein the vestibule and the floor of the mouth is extended for increasing the denture bearing area. Sometimes you may need to relocate the mental nerve, and examiners would be expecting this term an Orby-Geisers technique, in which you take a skin graft and you place over the ridge, and this will increase the depth also, and also it will increase the amount of stable attached tissue on the ridge. And some textbooks recommend implants in pre-prosthetic surgery. They say if you give an implant, you can eliminate most of the pre-prosthetic surgery procedures, especially when you see a tori or a genioplasty is required. Don't do that. Instead, you give implants, and then you can give an implant supported denture. So that completes the pre-prosthetic essay. And we'll see the next topic, last topic, which is implant overdentures. So if you want to learn about the implant overdenture, we should be knowing the different prosthetic options first in implant dentistry. So I'll just explain them and then quickly go into the implant overdenture session per se. So implant restorations can be classified as FP1, FP2, and FP3. FP1 is a fixed process. So FP means it is fixed processes type 1, FP1, which means it is a fixed processes that will replace only the crown portion of the tooth. So you only have interocclusal space to replace the crown portion. Limited interocclusal space you have. So this restoration, when it replaces only the crown portion, you call it as an FP1. There are two other classifications of fixed processes. It is an FP2 when it replaces missing portions of the crown portion and also the cemental region. I'll be showing you pictures of this, don't worry. FP3 is a fixed processes that replaces the missing crown portion, the missing cemental portion, and also the edentulous portion, ridge site. We'll see what it is. So when the resorption is too much, that it will, you have space to replace the cemental portion, then is an FP2. But when the ridge is also resorbed, so that you have to replace the crown plus the cementum plus the gingival portion of the edentulous ridge. Or when you see a pink portion on your restoration, which means that there is more amount of resorption that has happened, then you can give, then the restoration that you give is an FP2 when only you replace the crown and also a portion of the cementum. But when there is more ridge resorption, you see the ridge resorption here, when there is more of ridge resorption in which you have space to replace the crown plus the cementum plus the gingival portion of the edentulous ridge, then like this, it is called as an FP3. So we have seen what is an FP1, FP2, and FP3. Now, an implant overdenture is an RP4 and an RP5. So you should know what is an RP4 and an RP5. We'll be seeing that soon. So if a question is asked on implant overdenture can also be called as, it is a fixed detachable complete denture, which means that it's a complete denture only, but it is fixed onto something, but it is also detachable. It can also be said as it is an implant retained, but yet it is a removable denture. So presently, what we say is you should not give an ordinary complete denture. The present standard of care for a lower complete denture is at least 2 implants should be given in the mandible. So a 2 implant supported mandibular overdenture should be the minimum standard that should be offered for the mandibular edentulousness. So that is the present gold standard. So we'll see a clinical case. You'll see that this is an advanced bone resorption case. How do you know that this is an advanced bone resorption case? You see that the vertical dimension is less, and also you see there is no support for the flange, for the lip. You see that lip is gone inside, it has gone inwardly. So if you give a fixed prosthesis, you see still it is not adequate to bring this lip to this level. So you require a flange. So in such situations, you cannot give, when there's an advanced bone resorption situation, you cannot give a fixed restoration. So in such situation, you give a denture with a flange. So in such situation, you give an overdenture when there is an advanced bone resorption situation. So the interarch distance is very much more. So when the interarch distance is 18 millimeter or more, then an implant overdenture is indicated. Why you should require so much of space? That is for for cleansing action in between the bar and the undersurface of the denture. And then, so bar requires a certain amount of space, and the teeth requires a certain amount of space. So in order to accommodate all this, you'll require at least 80 millimeter of space above the mucosa to give an implant over denture. So you will see in this case, you have given 4 implants. 2 implants are at the posterior region and 2 implants are at the anterior region. So such kind of restoration, when you give both implants in the anterior and also implants are there at the posterior region, you call it as a RP4, which means it is a removable prosthesis type 4. Here, overdenture is supported completely by the implant. So there is no tissue support for this. It is completely supported by the anterior and the posterior implants. No soft tissue support. There are 5 to 6 implants in the mandible, and even you can give a cantilever posteriorly. But there are 6 to 8 implants that you give in the maxilla, and there is no cantilever in RP4 type of processes. So, but in advanced case, you see there is the mental foramen is on the top of the ridge. There is no bone left to place an implant at the back. In such situations, what you do is you place implants in the anterior region. So this is called as a RP5 when the overdenture is only supported by lesser number of implants, and that is only placed in between the intermental foramina region. And here, the overdenture is supported both by the soft tissues and also by the implant. So RP5, it's supported by anterior implants, which is placed intermental foramina region, in the intermental foramina region, and it is both supported by the tissue, retained by the implant, but is supported by the remaining ridge and the soft tissues. So where do you place implants? In the book called as MISH, which is said to be the Bible of implantology, they say intermental foraminal region, you've got 5 regions, which you call it as A, B, C, D, and E, where C comes in the mid-symphysis region. So if you draw this picture, it is very good. Now the disadvantage is it is only supported in the by the implants in the anterior region, whereas posteriorly it is both supported by it is only supported by the ridge and the soft tissues. So since it moves, there is still chances of resorption happening in the posterior region. So that's a disadvantage of an RP5 process. There will be continued resorption of the bone at the posterior region, and since it is always moving like up and down, there will be wear of the processes of the attachments. So how many implants that you give in maxilla? If it is maxillary overdenture that you give, a minimum of 4 implants. And where do you place this implant? You place it in canine regions and in molar region ideally. So at 6 and 6 and canine and canine. So this is how we place the maxillary implant. You can also place 6 implants in maxilla. The advantage of maxillary overdenture is that you can eliminate the flange and also a crossbar stabilization, which you have seen in your RPD situations. So you can give a horseshoe kind of overdenture. The advantage of overdentures is that since the movement is reduced than a complete denture, it will reduce soft tissue abrasions. It will give you more chewing efficiency. You can even bite with the anterior teeth. It can be removed at the night, so that will relieve the mucosal stress, and it is always reduced lab fees for a removable denture than a fixed implant denture. So the different type of attachment that you give us, you can have separate implants which are not connected together, but you can have splinted implants also. So you should mention this. Attachment types are separate and splinted. So we'll see the different type of non-splinted or separate attachments. One is a ball attachment you can give, or the most favored design for the attachment. Attachment is the thing that comes over the implant that you place. So it is the presently most favored kind of attachment design is a locator attachment. So ball attachment and locator attachments are generally favored attachments for a non-splinted or a separate attachment design. And also you can splint the attachments together. So it is called as a splinted attachment or a bar attachment. Not splinted, the advantage is, you you gain more support from the distal region, from the denture bearing area. So it has to be supported, get support from the ridge areas, and you get only limited support by the implants if it is separate. And you see, this will act as a fulcrum, and your denture can rotate around this fulcrum. So that is the disadvantage. Whereas when you splint them together and you give a bar like this and a clip over this, the advantage is the posterior movement, the rocking movement is reduced. So the patient will gain a more comfort, or patient can get more retention when you give a bar kind of restoration. But the problem is it will require more space to accommodate the bar. And sometimes you see it is unclenchable under the denture. It can result in papillary hyperplasia or mucosal hyperplasia under the bar, since it is very difficult to clean under the bar. So always when you give over denture, it is always recommended that the denture should always have a metal backing like this. Otherwise, these regions where the female housing comes, it can act as a stress concentration region, and it can result in breakage of the denture. So this completes the today's session, and I'll just summarize this point. So we have seen the different types of implant dentures. One is a fixed partial dentures that you can give, and removable dentures. Removable dentures are over dentures. There are two types of over dentures. One is a RP4, in which there is no mucosal support. If there is bone for placing implants in the anterior region and posterior region, and you can support like a chair, like the four legs of a chair. This denture will be supported by the at least minimum of 4 implants, 2 implants placed in the anterior and 2 implants in the posterior. Whereas in RP5 processes, there are implants only in the intermetal foraminal region. You can place 2 implants or 4 implants or 5 implants as such, and this denture will gain retention from the implants, but support and stability comes from the ridge regions. So thank you for your patient listening, and I'm conducting a basic implantology class on 24th and 25th. It will be a hands-on class, July 24th and 25th, just for beginners. For those people who don't know anything about implantology, you can contact me for this class. Thank you very much, Online Dentistry, for inviting me and the support you have given me for this class. Thank you very much.
Thank you so much, sir.
Thank you.
Thank you so much. Anybody have any doubts, please come in. Please put in the chat box, or else you can even put in the WhatsApp groups you are in. We will definitely ask sir and get the reply. But if you can put in the chat box, we have around 8 more minutes remaining in this. Sir also has another meeting to attend, I guess. But we are open to questions if any. But your topic you took and the way you explained was so crisp. Okay, please enlighten on I-beam effect and ferrule.
Okay. You see, this comes in 2 different planes. So in the anterior region especially, there is one plane, and then the anterior rugae region, it comes in another plane. So this will contribute to 2 different planes. When you have 2 different planes, that will result in rigidity, more rigidity for the restoration. That is one question. And the second question is about the ferrule. Ferrule is when the core will retain on the crown will retain on the tooth only if there is enough tooth structure beyond the core. So if the margin of the core is resting, if the margin of the crown is exactly at the margin of the core, it can result in fracture because there is no support from the tooth. It gains the crown gains support only from the core. In such situation, it can result in fracture of the tooth. So when you give a crown, there should be at least 2 millimeters of tooth structure to support the crown beyond the core margin. If you don't have 2 millimeters of space, the picture which I had shown, I had actually done an electrosurgery to remove some part of the gingiva, and I've done a crown lengthening, removing a little bit of the bone also. So you gain natural tooth structure beyond the core margin to support the crown. So that is what is called as a ferrule effect.
Any criteria for selection of material for post and core other than aesthetics?
Presently, even with the zirconia, even if you give a metal post inside, you can definitely mask the black color of the metal. So clinically speaking, even if you give a metal crown, metal core, or aesthetic core, actually it doesn't make much of a difference, because we can generally mask the color of any material with the present day Emax or even with the zirconia crowns that we get. And generally fiber posts are not as strong as metal posts. So, it depends upon the clinician's choice. Generally, what I do is when you have more tooth structure, then you can do, I generally do a fiber post. But when there is very limited amount of tooth structure remaining, then I'll go for a cast post.
Sir, how to answer a long answer on how to design an RPD on Kennedy's class 1? What are points we need to explain? What are the points? I don't know, what capital R points we need to explain?
Can I read that question? Because,
Sir, how to answer a long answer on how to design an RPD on Kennedy's class 1?
Okay, that is complicated question, because it's very short of time to explain that. But what you can do is, you should generally draw a picture on the Kennedy's classification if they have asked Kennedy classification 1 or 2, and then you should mention about the different parts of a cast RPD, like rest, direct connector, different clasps that you give, and then you should mention about the kind of major connector that you would give and why, and the kind of minor connectors that you give and why, and the kind of rest seats that you give, the primary rest seats and the auxiliary rest seats that you give, and whether it's a mandibular or a maxillary situation, and the different types of design that you will choose. You should also know about the color coding that you should mention to the lab. I hope you know about the color code. So if you are asked to draw a lab communication or a design, what you should do is, the color coding for a rest seat preparation is red. Red means it is dangerous, which means that you need to trim away tooth structure. So wherever you plan your rest seat, generally rest seats are prepared next to an edentulous region. So you'll draw the picture, and then you will mark in red those regions where you should trim away the tooth structure in red. And the saddle is generally marked in blue color. So you should have color pencils with you, and the saddle is marked in blue. Whereas the metal regions, so that means the minor connector or the major connector that comes, wherever metal comes, it is either marked in brown or sometimes in black. And the survey lines are generally marked in black color, because it's a carbon pencil that you use. So you should, whenever you draw a design, you should have different color pencils also to design, and to, designing is to communicate to the lab your ideas that you want. And then you should also mark in the paper that this is a circumferential clasp that you design, and why you're choosing a circumferential clasp instead of a gingerly approaching clasp. All that you should clarify the choice of a design. The color coding is given in Red, Moro, Stewart. I love that book. Last time also I told that Red, Moro, and Stewart. That is the book to learn designing and cast RPD for PGs and even for undergraduates.
So Restore, thank you. And there's one question: basic implantology program is on online dentistry. So no, it's not an online dentistry. Sir is running his own successful program for so many years now in Kochi. It's a great program, and I am a person who always say implantology is for prosthodontists. I might be wrong there, and I always feel it's the final prostho part that really matters when it comes to implants. I might be wrong, sir. I don't know. Because end of the day, it's not what you screw it and what you get on top of it that really matters. Yeah. So anyway, he's running this program successfully for many years now. So you can contact him personally on that. It is not part of online industry, but yesterday we had this discussion on a tie-up with a UK-based firm where Sir is already a faculty. So online industry might get soon tied up with an UK-based firm, and again, hope that works out soon, sir. We have to work on it, sir. So thank you very much, sir. Once again, questions are done. It's all thank you from the candidates. So that's it. Thank you so much for your time, sir. So next we are slowly planning to come out with clinical part, the practical explanations. Also, we are planning to come with discussions are going on that. We will definitely update in the corresponding groups you are in. So once again, Dr. Elder sir, thank you so much. Good night.
Thank you very much.
Good night.